Hi, everybody. Thanks for tuning into this webinar. I'm going to be discussing some research around diagnostic labels for musculoskeletal pain. I call them diagnostic labels. You might call them terminology, language we use with our patients. And the goal of this webinar is to get us all thinking and reflecting about the potential benefits and harms of using different labels, language with our patients. And just to say before we get into this, research on labeling is still quite limited in the pain field. It's in its infancy. So I'm going to stay away from making any large claims, but I do hope you leave with a greater awareness of the role of language and labels. So why bother studying diagnostic labels for musculoskeletal pain? There's lots of other things we can research. So you can see I have 3 pictures here on the slide, and the 2 on the right, so there's one about diabetes and there's one about hypertension, or what they're now called pre-diabetes and pre-hypertension. So when I was young, or younger, I'm still young, the labels were hypertension and diabetes. So you either had high blood pressure or you didn't, you had diabetes and you didn't. So we see this real interest and enthusiasm in giving people more labels, more terms, more things to indicate disease. And worldwide, there has been an increase in the use of diagnostic labels, not just for blood pressure and blood sugars, but also for psychological symptoms. And with this concern, with this, diagnostic expansion, use of more labels, there is more and more concern that we risk creating a larger pool of sick people, so more patients, because we're extending labels to individuals who are either asymptomatic or experience mild symptoms. And some of this might have benefits, which I'll discuss later on, but often less considered are the problematic and negative consequences of a label. And this review here on the screen that was published in BMJ Open by an excellent group in Australia shows these negative aspects really, really well. So it looks at studies that examine the effects of different labels, particularly medical labels for different conditions. So that included polycystic ovary syndrome, gastroesophageal reflux symptoms, eye symptoms, fractures, and found that if for the same condition, if you vary your words, if you vary your terminology, it has a large effect on how patients think about care, what kind of interventions they want, and how they feel about that condition, how anxious they are, how confident they will get better. So when we bring it back to pain or musculoskeletal pain, like other fields, we have a lot of labels we use. And that makes sense, how we're trained, whether you're a manual therapist, whether you're an exercise therapist, whoever you are, we're trained to think, find the problem, get a treatment that acts on that problem. So, that's not just within our field, but it's common across healthcare and medicine. And a lot of these labels, are then directly communicated to the patient. So obvious ones are disc bulges, osteoarthritis, bursitis, degeneration, these common ones. But others that can be also harmful, maybe ones that we don't think about as much, are postural labels. So where we can take healthy people, we screen them, we screen their posture, we might give them, some postural labels around problems they have. And this might trigger anxiety about future pain, or also trigger some interventions where people try and fix a problem ever before they even have a symptom. And then we also have another example, which isn't always classified as a diagnostic label, but it's pain as the 5th vital sign. And that was a label where there was lots of over-detection, over-attention to pain, and is now widely accepted as one of the key contributors to people getting more and more opioids for pain. So lots of labels in the pain field, and we don't really know have they benefits or harms. So there are, of course, benefits. We need labels, and labels have their benefits depending on the symptoms a person presents with, the person getting the label, their beliefs, their psychological status, how they're feeling, and perhaps the setting and the healthcare system of the relevant country. So examples are, if you get a label for a certain condition, it might grant you access to care and resources that you might not otherwise get access to. And this can be very positive if you have a specific condition that needs a specific medical treatment. Not knowing what's wrong with you can be very frustrating. Getting a label can make you feel heard and validated, and that's very important. And maybe not getting a label can make a person feel dismissed. Beneficial accommodations or modifications. This could be at work duties, it could be at home, things that maybe you might not receive if you do not have a specific diagnosis to fit your symptoms. It's also very frustrating not to understand your condition. So as well as not feeling heard, once you are given a label, maybe it can increase your knowledge about that condition. You feel a bit more confident in managing it depending on the information you receive. And finally, it may reduce stigma. So some symptoms are maybe viewed negatively in society, particularly if there isn't a real condition linked to them. So that can be another advantage of getting a label. So it isn't all, it's not all cons or disadvantages. The harms then are, if you're given a label, particularly a label that you maybe do not need, or it doesn't inform an effective treatment in some way. Potential harms that we could be concerned about is negative beliefs. So beliefs about what you're able to do, your body, etc. Distress. So maybe it causes you to feel very anxious. Maybe it causes you to think a lot about your symptoms. Maybe makes you very anxious about your future and what you can do. A big one seems to be unnecessary tests. So it works two ways. A person could get an unnecessary test and get a label, and that can, trigger more tests. But also a person that might think they have a medical condition might be more likely to want imaging as well. So an example of that might be back pain. Preferences for invasive treatments. We see that across a number of conditions outside of pain. So people might prefer to get surgery. They might prefer to get an injection if they view their diagnosis as having a very strong structural component. And along with negative beliefs, we could have negative behaviors. So a person could restrict their activities. There might be a reduction in their independence. They feel they can't do things as well. So just to give in musculoskeletal pain field, we'll give low back pain as an example where there can be benefits and harms. So this is just a diagram really of the diagnostic triage process for back pain. And here the diagram divides back pain into three main bundles, I guess. And if we think of number one, specific spinal pathology, an example would be fracture, cancer, infection. Getting a label in this instance is really, really beneficial because you're dealing with a dangerous condition that needs a specific treatment. That label will inform a different treatment pathway for you than having non-serious symptoms. Radicular syndromes can be uncertain, but if you have for example, a nerve root compression or something that's producing a lot of motor symptoms, again, having a diagnosis in that case can be very important and can inform treatment. The problem is if we're talking about the big basket of back pain where, well, this is argued, people will argue that maybe it shouldn't be this big, that we can identify a lot of sources of back pain. But if we call a lot of low back pain non-specific, where we're unconfident if it's driven by a specific structure, if it's emerging from a muscle, a joint, and so forth, it can make us kind of scratch our heads around, okay, what kind of label do we give a person when they don't clearly have a structural issue that we can identify? And this is the group that I like to focus on in my research when it comes to labels. So I did me and my colleagues, we did a randomized control trial in the area of low back pain. And we really wanted to put labels to the test, as in, do they really have benefits or harms? Because a lot has been spoken for a very, very long time about potential downsides, but without doing some test, it's very hard to know. So we did a trial about 2 years ago now at this stage, and it aimed to examine whether different labels for low back pain influence whether a person wants imaging, whether a person would like to go for surgery, whether they need a second opinion from a surgeon or a doctor, and other outcomes like how serious they perceive their pain to be, how likely they think they'll recover, and also beliefs about physical activity and work. So we measured lots of things. And what we did is we did the full trial online. we recruited people with and without low back pain because we wanted to see, do labels have an effect on people that have never had back pain before? Maybe people would react not as bad versus someone that has already received a label or has had some experience with the healthcare system. We got a company called Qualtrics to recruit lots of people online through market research panels. We recruited people from Australia, Canada, and Ireland. The main reason we picked those at the time is they seem to have similar healthcare systems. We could have gone for other countries as well. And once people were onto the online platform, they were given a scenario or a vignette describing a person with non-specific low back pain. And it went on to explain, you have back pain, you have these symptoms, you went to a GP or a physio and they did this. And then you were randomized to one of 6 labels. So the labels we used were disc bulge, degeneration of the spine, arthritis, a lumbar sprain, non-specific back pain, and an episode of back pain. And each label was accompanied by the same advice that the condition wasn't serious and would likely resolve over time. So a person would be told, you have, for example, a disc bulge, and then they would get some positive advice. I'm not worried that there's anything serious going on here. I think your outlook is good. Movement will help. It will be better for you when you get back to work and so forth. Because we wanted a bit of advice in there to see would it have some impact on the label. And we assessed results immediately after the scenario. There was no follow-up. It was just their immediate follow-up. And the main outcome was imaging on a 10-point scale. And the other outcomes, surgery, second opinion, and the rest were measured in a similar way on a 10-point scale as well. And I haven't put a lot of data like numbers on the slide because there are so many results to present and we were doing a lot of comparisons. But the results were very clear. So 3 labels emerged as better, I guess if you can use the word better, than 3 other labels. And they were episode of back pain, lumbar sprain, and non-specific low back pain. They emerged consistently as giving participants a less perceived need for imaging, second opinions, and surgery compared to disc bulge, arthritis, and degeneration. The same labels were also associated with less seriousness and better recovery, but we didn't see any difference in beliefs about work and physical activities across the labels. So that was also interesting because that's a claim that's often made about various labels. And we also did this qualitative study as part of the trial. So embedded in the trial, we also asked people a question, when you hear this label, so for example, when you hear disc bulge, what feelings and words come to mind? And I'm going to give you some examples of the quotes, but just to summarize, when we analyze the quotes, poor prognosis, so low chances of getting better, emerged a lot more frequently for bulge, degeneration, and arthritis, whereas good prognosis or, positive expectations about recovery were more common for sprain, non-specific low back pain, and episode of back pain. So this is interesting because it fits with the quantitative data. Thoughts of tissue damage were less common for non-specific low back pain and episode of low back pain, quite high for lumbar sprain in particular. The only thing for non-specific low back pain that while the other outcomes were something we consider positive, there were high feelings of uncertainty with non-specific low back pain, which probably makes a lot of sense when you're as good as telling a person you have no idea what's causing their pain. And these are just some quotes that really hit home around the role of language and how people perceive some of these labels. So a disc bulge, we have a participant saying a disaster, a lifetime of pain, another saying possible paraplegia, another using a wheelchair is unavoidable, an external body bulge that sounds life worsening. It doesn't sound like it will kill me, but it sounds it will ruin many physical parts in my life. So that's just 2 words, that can have this negative impact. And that's also on younger participants as well, as you see in the text there. Just an example from degeneration, and this was very consistent. These types of quotes, these kind of negative, really expecting a poor outcome, these type of quotes were very, very common for degeneration. So I'm not just cherry picking ones, but one participant said dying spine, I reckon. So you can imagine if someone thinks that, you know, how they engage with manual therapy or exercise or any form of treatment, you just wonder if they have that negative perception. Again, wheelchair is mentioned, the spine crumbling is mentioned. So all of these things are really negative, scary things for a patient to believe and to think. And again, just a few more examples of arthritis. Wheelchair again is mentioned, whereas that would never be mentioned for non-specific low back pain or episode of back pain. Pain like broken glass, grinding between your bones. That's all very, very visual, very scary. You don't expect that patient to be very confident about getting better. And I'm getting old, you know. So again, a negative view of where they're going. And I guess what some people would ask, is this just low back pain? Is this something that's just specific to low back pain labels? And what we can say is no, it applies, it's now applying, we can see it applies for other conditions as well, because in recent years, there's a lot more trials coming out now. It's still limited, we need more, but in shoulder pain, hip pain, neck pain, we're seeing, you know, similar results. So they're just two examples, one from our group, the other from another group in Australia, Travis Haber. He's doing his PhD. He's doing excellent work in the area of hip pain and how we might explain it better to patients so they're, you know, not scared by labels such as hip osteoarthritis. So it's not just a back pain problem. It seems to be across pain conditions. And I guess a clinician listening to this could say, well, okay, the labels have these negative effects. What can I do? You know, is there anything I can say? Is there anything I can say to a patient to make them feel better about it? And it's kind of uncertain at the moment. We think, based on one study we've done in shoulder pain, that if you provide very good advice, very good reassuring information with a label, it seems to reduce the effect of the label. You know, so it could be the case that if we design better educational material, even in people that have been given a very scary label, we might be able to undo the effects, which would be great, but we don't have the data to say that at the moment. But advice or our education could emerge as more important. So unknowns, lots of unknowns. As I said at the start, the research is still limited. We have some trials. We have some excellent new PhD students doing work in this area, also with patients and, you know, around what labels would they like, but some big unknowns. So what should a clinician say when an individual arrives with beliefs and behaviours after a label? Because outside of us giving labels, people often come to us with an imaging scan or report, the label is on it, they already have the beliefs and behaviours before they reach us. We're unable to say at the moment how we can reduce the effect of that label. So that's an unknown and something we're working on. Are there better labels and explanations to use? So there is some work going on in this area as well, where maybe patients and clinicians would work together and think of better explanations that better maybe represent their symptoms than something like maybe non-specific low back pain. Because even though it emerged good in the quantitative data, there were still problems around uncertainty with it. System pressure. So in many countries, many hospitals, a person has to get a scan and has to have a label to really get treatment. And how do we change this, you know, trend? Can it be changed? We don't know. So that's a big thing. People need to legitimize their pain with labels. And stigma and exclusion associated with not having a cause for back pain. So if we opt for labels that are less medical, like episode of back pain or non-specific, do you run the risk of introducing other problems for that individual? So some take-home messages based on the research. Our words matter. What we say, how we use labels matter. Low-hanging fruit, appropriate labeling is free of cost, risk and effort. So it's something I think we should try to do, particularly if a person hasn't received a label yet. I say low-hanging fruit because we don't have a lot of very effective interventions for a lot of conditions. And this might be, you know, a potentially very important thing that could have an effect on outcomes. Consider avoiding terms like disc bulge degeneration and arthritis if you can, because it seems across hip pain, across shoulder and back, none of these labels appear as really positive. And if these labels aren't informing some new treatment pathway, they're probably unlikely to be helpful. And finally, changing how we label conditions like back pain may reduce, I say may because we need more research, may reduce unnecessary care, increase the acceptability of non-medical options, whether it be manual therapy, exercise, which is safer, and promote recovery. This is just some recommended reading, 2 papers on this area. So we recently published an editorial on labeling musculoskeletal conditions. So it runs through a lot of the papers that I've actually discussed. And also there's a really interesting paper on avoiding nocebo and other undesirable effects in chiropractic, osteopathic and physiotherapy. And it's very interesting because it also mentions language in terms of having that negative effect, which is called nocebo in this article. Finally, I'd like to acknowledge the people I work with on the labelling studies. So Joshua Zadro, Giovanni Ferreira, Ben Darlow, Chris Marr, Ian Harris, Ray Thomas, Rochelle Buckbinder.